Hello everyone, and we have the MCQs here again. I'm back, and it's like first one it is like which of the following, that is which is the first order neuron in the optic pathway. It's rods and cones, ganglion cells, cells in the lateral geniculate body, or it's bipolar cells. So I will repeat once again. Usually I am discussing 25 MCQs here, and the first question is which is the first order neuron in the optic pathway. It's a rods and cones, ganglion cells, cells in the lateral geniculate body, or it's a bipolar cells. So yeah, it's an easy question, but if you know the anatomy, you can just tell this. What is the pathway for the optic nerve? Like what is the first order neuron in the optic pathway? It's rods and cones, ganglion cells, cells in the lateral geniculate body, or it's a bipolar cells. So yeah, it's an easy one, but if you know, then only you can just tell. So yeah, which is the first order neuron, second order, and then you can just tell like that. So yeah, I will just tell. It's the answer is usually it's rods and cones. A is the right answer. So in case of optic pathway, the first order is that is the rods and cones is the first order neurons, and then we move on. It's like a bipolar cells, ganglion cells, and then we have the axons from the lateral geniculate body. That is optic radiation we see basically. So yeah, there are the fourth order neurons are there. So yeah, I think you have heard this, and next we move on. It's like this. It's very simple. It's a photoreceptors, bipolar cells, ganglion cells, and it's a lateral geniculate body. Next question we have is it's a PSM question. Yeah. So you might be knowing what is a modified Kappa-Swami scale. Anyone knows what is a Kappa-Swami scale? So if you know it, you can just answer this. It's a case of a modified Kappa-Swami scale, and we know it's used for socioeconomic status. So you can just tell me what are the three criteria in Kappa-Swami scale if you can. We have BG Prasad scale, Kappa-Swami scale, and Uday Pratik scale. So yeah, if you can just tell what are the three things we use for a Kappa-Swami scale. I can no one is interested here, but yeah. Okay, we have three things in Kappa-Swami scale. We have one is the education of the head of the family, then we have the occupation, and then we have the monthly income of the family. So yeah, it's like education of the head of the family, it's occupation of the head of the family, and it's the monthly income of the family, which we consider for a Kappa-Swami scale. Basically the question was you have to match the following, but yeah, you cannot just match the following without telling that. I'll just tell you it's like socioeconomics class they have given. It's a low, upper middle, middle, upper lower, and so lower. So you have to remember the classification. I'll just say it very fast. It's a upper classification. We have a 25 to 29, the scoring system, and that scoring I told you is based on three things. The scoring for Kappa-Swami is based on three things, and first was education, income, and what was that? It's income and occupation. So yeah, it's like a upper, that is 25 to 29. Upper middle we have, lower middle, upper lower, and the last is lower, that is 0 to 4 is the score for the Kappa-Swami scaling. Let's move on. Succinate Q erectus belongs to which complex of the ETC? So yeah, if you know, it's a complex 1, 2, 3, and 4. So yeah, it's a biochem question. All the questions are like that only here, but yeah, if you want to answer this, it's a succinate Q erectus belongs to which complex of the ETC? It's complex 1, 2, 3, 4. Okay, I don't tell. It's like I have to remember it's complex 2. Basically, it's a ETC. You know, it's a catalyzed oxidation of succinate to fumarate. That ETC, you know, it's an electron transport chain, and in that it is complex 2, which has a succinate Q erectus enzyme. So yeah, I cannot just tell because you have to just remember that. So yeah, it's a complex 2 of ETC. Next we move on. Yeah, I think this one is okay only. It's also a biochem. But yeah, how much drug will remain at the end of 6 hours when a patient is given 200 mg drug, 75 mg is treated in 90 minutes, and if the drug order follows first order kinetics. So yeah, there is one formula in first order kinetics, that is TF is equal to 0.693 into something. It's like that. I'll just tell the formula again. If it's there, they have given in the. So they are not asking for TF only. Okay, sorry. Okay, they are asking how much drug will remain at the end of 6 hours when a patient is given 200 mg drug, 75 is treated in the 90 minutes. So, and if the drug follows the first order kinetics. So yeah, in first order kinetics, the constant fraction of the drug will be excluded in the given time. See, in zero order it is like that only, but in first order we have the formula which they haven't given. I think it's like TF equal to 0.693 into concentration or something. It was like that only. So yeah, it's like 75 mg to 75 mg of 200 mg restricted in 90 minutes, and then we have after 90 minutes it's like it's a calculation we have to do. It's after 90 minutes what will happen. So it's like 30.5 mg. So yeah, there is no, it's a simple way also, but yeah, it's a unitary method they have given. So I know I will just tell you get bored. Already you are bored with this, but yeah, next we have, I think it's a interesting one. We have a 18-year-old destitute woman reports to a free eye cam with vision problems. So best corrected visual acuity was 6/12 in the right eye and 6/6 in the left eye. So elevation in the right eye was absent. Her right eye shows 14 to 16 prism diopter hypertropia, and Bell's phenomenon was absent in the right eye. Diagnosis of the right eye double elevated palsy was made, and which of the following muscles are affected here? Because you have to remember there is a diagnosis, that is the elevator palsy, that is double elevator palsy they have given, and which of the following are muscles which are affected here. So yeah, the options are, it's a levator palpebris superior to the Muller muscle, it's a levator palpebris superioris and the superior rectus, and then we have a Muller muscle and the inferior oblique, and then the last option is superior rectus and the inferior oblique. Basically there it's a case of a ophthalmic case, and it's a double elevator palsy in the right eye. So basically you have to tell the which of the muscles are affected in case of a double elevator palsy. So if you know it's palsy, which is the muscle, anyone want? Am I there? It's video has come back. Okay, so in double elevator palsy, which is the muscle which is involved here? Anyone wants to answer? It is commonly associated with ptosis and pseudotosis. That is okay, but yeah, okay. The answer is basically it's like a superior rectus and inferior oblique is the right answer. So you have to think in that way. It's a superior rectus and inferior oblique, and we have a double elevator palsy. So next we move on. A young man who got injured in the neck while diving is brought to the emergency. Yeah, superior rectus. Oh, you are there. I think no one is there. Okay. So yeah, it's a superior rectus and inferior oblique is there. Okay, next we had a young man is there who got injured in the neck while diving is brought to the emergency. So which of the following classification system is unlikely to be used to classify his injury? It's a A.O. Magral classification, it's a Allen Ferguson classification, Anderson and D. Olonjo classification, or it's a Levine and Edwards classification. So yeah, I know you have to name the classification here. Basically it's a case of a neck injury, that is a cervical spine injury they are asking, and what is the classification we use for cervical spine injury? It's a A.O. Magral classification, Allen Ferguson, Anderson and D. Olonjo, or it's a Levine Edwards classification. So yeah, if you know the answer, it will be better. Basically it's a thoracic lumbar spinal injury and all that. Yeah. Okay, I will tell you the answer here is A, that is A.O. Magral classification we generally use. And the given scenario I already told you, it's a case of a cervical spine injury, and we use a A.O. Magral classification, that too for thoracic lumbar spine injuries. So yeah, what is there? It's 3 types, and it's based on the really primary force and the caused injury. And it's like a 3 types: A, B, and C. A is the compression force, B is the distraction force, and T is the torsional force. So yeah, we have 3 classifications. First is Anderson, D. Olonjo, and Levine Edwards, that is for hangman's fracture. And then Allen and Ferguson classification, that too it's for the subaxial cervical spine injury we do it. So yeah, next question we have, it's match the following. It's a difficult one, but yeah, match the following surgeries for femoral hernia with their indications. So I'll just tell the answer here, because if you, I don't think I will be able to match the following. I haven't seen, but yeah, okay. So yeah, the answer is, I'll just tell which are the surgeries which we use for a femoral hernia and their indication basically they have given. So the first is Lockwood surgery. So if you know what is Lockwood surgery and where do we use, and then want to answer this Lockwood surgery. It's a femoral hernia. Okay, I will just tell the answer here. It's a Lockwood surgery, and we do it for an elective repair. That is, if you have an elective repair for a femoral hernia, we do a Lockwood surgery. Then MCQs surgery we do for a bowel infarction. So if the bowel has come in the femoral hernia and there is an infarction, we will do a MCQs surgery. And then we have a Lothinson surgery, and Lothinson surgery is also femoral hernia repair only, but in a Lockwood operation we do for elective repair. So yeah, it's a, if you want to do elective repair, there will be a Lockwood operation, And if you have a bowel infarction, we will do a MAC cavity surgery. And then we had, suppose if you want to go to a transinguinal approach. So in case of a transinguinal approach, we will go, the surgery is called as Lothenson surgery. And the last is McAvoy surgery. It is for both inguinal and femoral hernia. So you have to remember the names of the surgeries here. So yeah, for last time I will tell, it's a Lockwood elective, McAvoy bowel infarction. If you want to go to the transinguinal approach, it's the Lothenson surgery, and it's for both femoral and inguinal hernia. It's a McAvoy surgery. So yeah, the names are there, you have to remember. So next we have a 38-year-old woman who comes to you with a chest pain, and that was unrelated to the physical exertion, because there is no muscle, there is no trauma or something physical exercise she hasn't done, and she comes to you with a chest pain. So yeah, the woman comes to you with a chest pain, and the ECG is given. ECG basically it shows the ST segment elevation. So whenever you think of ST segment elevation, you first think of MI, but yeah, let me complete. Then we do a intracoronary acetylcholine provocation testing, revealed a transient spasm of the right coronary artery. So what is the drug of choice for this condition? Yeah, it's an easy question, but if you know, I'll just tell. It's a ECG showing ST elevation, and she comes to you with the chest pain, and there is a intracoronary acetylcholine provocation testing you do, and it will show a transient spasm of the right coronary artery. So what is drug of choice? The options are dopamine, diltiazem, propranolol, or it's a digoxin. So yeah, it's an easy one, but if you know what is the above case, it's a ST segment elevation and there is a transient coronary vasospasm. Yeah, it's very typical. It's a typical of a diagnosis. If you know, it's a transient coronary vasospasm with ST segment elevation, and the diagnosis is, if you can tell, if you know the diagnosis, you can just tell the drug of choice. Okay, I will only tell. Basically the diagnosis is basically it's a fringe metal angina. So in case of a fringe metal angina, you know there is a vasospasm, that is coronary vasospasm will be there, and with the vasospasm there will be a ST segment elevation. So and the drug of choice for fringe metal angina, you know, it's that is a calcium channel blockers. Yeah, it's a calcium channel blockers, and the right answer is diltiazem. So diltiazem is the drug of choice for a fringe metal angina. So yeah, there will be a rest pain and ST segment elevation. It's a hallmark basically. Yeah, it's MI also can be there, but it's not MI, it's before MI, because there is a vasospasm in this case. So in case of a vasospasm, you cannot just think of MI. ST segment elevation is there, but it's not that typical. So yeah, where I was, it's yeah. It is a supply of ischemia, and usually it causes transmural ischemia. Yeah, ischemia it can cause, but at the first you cannot give. So yeah. Yeah, okay, next we move on. A man who works in a cattle ranch presented with complaints of a mass protruding from the left nostril and blood-stained nasal discharge. The mass is pinky, leafy and polypoidal and is attached to the nasal septum. Biopsy from the lesion shows several sporangia. So you have to think what is a several sporangia basically. What is the treatment of choice for the above condition? So it's also an easy one, but yeah, if you know what your diagnosis, then you can just tell what is how will you treat this. I will just repeat. It's a man who works in a cattle ranch presented to you with a mass protruding from the left nostril and a blood-stained nasal discharge. So the mass is pinky. It's very typical feature. It's a pinky mass, pinky, leafy, and polypoidal in nature, and is attached to the nasal septum. So and the biopsy you will do, it shows several sporangia. So what is the diagnosis? If you can just tell. And basically the question is, the treatment of choice for this condition is, options are streptomycin, ketoacetylene, radiotherapy, excision with cauterization, or it's a dapsone. But yeah, if you know the diagnosis, it will be very easy for you to just. Okay, I will only tell. It's okay. The answer is excision and cauterization is the right answer. What you do in this case? Basically, what happens is it's a case of a rhinosporidus. It's not a nasal polyp can be there. But see, in nasal polyp there won't be this one, sporangia. Sporangia won't be there in nasal polyp. So it's a typical of a rhinosporidiosis. So yeah, it's a rhinosporidiosis and can present with polyp, but yeah, but it's a typical of rhinosporidiosis, and the management is excision and cauterization. So yeah, and dapsone can be used, but it is not that effective. So yeah, so the answer is it's a surgical management, that is excision and cauterization you have to do. Next we have is which of the following parameters cannot be viewed in the lateral plate X-ray pelvimetry. So you are doing a lateral plate X-ray pelvimetry. So which of the following parameters cannot be viewed? It's a diagonal conjugate, it's a through conjugate, bispinous diameter, or it's an inclination of the pelvis. So I repeat, so which of the following parameters you won't be able to see in a lateral plate X-ray pelvimetry? It's a diagonal conjugate, through conjugate, bispinous diameter, it's an inclination of the pelvis. So yeah, it's a basically factual question, but if you know, it's good only. So I want to answer this. Okay, the answer is basically, I also don't know the answer, I also don't know now. So yeah, it's a C, that is the bispinous diameter cannot be viewed in case of lateral plate X-ray pelvimetry. So in C, it's normally it is in AP view. In AP view you can see a bispinous diameter, but in lateral view you won't be able to see that. So in lateral view what you will see, it's you can see a diagonal conjugate, through conjugate, inclination of the pelvis you can see. So yeah. So you know there are AP view, lateral view and outlet also, and CT pelvimetry is preferred over the X-ray pelvimetry. We don't do nowadays, we don't do this, but yeah, CT pelvimetry is preferred over the X-ray pelvimetry due to the lower dose of radiation which is given CT pelvimetry. So yeah, let's move on. We have a question like, which of the following is not a part of 2025 HIV targets of a global AIDS strategy 2021 to 2026? Yeah, it's a PSM question. It's unlikely, it's likely we can know also, but yeah, I'll just repeat, which of the following is not a part of 2025 HIV targets of global AIDS strategy 2021 to 2026? Options are: 95% of women of reproductive age have their HIV and sexual and reproductive health service needs met. 90% of the people living with HIV receive preventive treatment for TB. Or it's like 95% of the pregnant and breastfeeding women living with HIV has suppressed viral loads. And the last option is, it's a 75% of the HIV exposed children are tested by 2 months of age and again after cessation of breastfeeding. See, it's a PSM question. I also don't like PSM. If you like, it's a very good thing, but yeah, it's a PSM question, and basically it's which they're asking which is not a part of 2025 HIV targets of global AIDS strategy. And I'll just tell the answer. It's like, I will tell just what is the, yeah, it's D is the right answer. Yeah, so it's not basically it's not 75, it's what was the test, it's 95% I think. Yeah, it's 95% of the HIV exposed children are tested by 2 months of age and again after cessation of breastfeeding. So yeah, D is the right answer. I think you know PSM very well. So yeah, it's a 2025 HIV targets, and right answers are 95% of the women. Right answer means it's not 2025 what they are. It's 95% of the women of reproductive age have the HIV and sexual and reproductive health service needs met. Second one was 90% of people living with HIV receive preventive treatment for HIV. That is also there. And 95% of breastfeeding and pregnant women living with HIV have suppressed viral loads. And the last one was 75% of the HIV. It's not 75, it will be 95% of the HIV exposed children are tested by 2 months and then again after cessation of breastfeeding. Next we move on. It's a patient who comes to you with a right-sided hemiparesis that completely resolved in 4 to 6 hours. So what score will you use to determine the risk of a future stroke in this patient? So there is a scoring system. If you know, there is a scoring system for stroke. So basically they are asking, suppose a patient comes to you with a right-sided hemiparesis and then completely resolved in 4 to 6 hours. So what score will you use to determine the risk of future stroke in this patient? Options are, that is a CHADS2, VASC, or it's a curve 65, ABCD2, APAC 2. So yeah, if you can just rule out which classification you are using where, because see, in case of a curve 65, it's I think curve is in that case only, it's a pneumonia. That was I was thinking. So yeah, so basically in case of a stroke, which scoring system will you use? It's a CHADS2 VASC or a curve 65 ABCD2 or it's a packet 2. So yeah, if you can answer this. So see, curve 62 I told it's in pneumonia, it's in community acquired pneumonia. We use curve 63. A packet also we use in ICU cases. For mortality we determine the ICU mortality in case of a packet 2 scoring, and CHADS2, that is VASC, is used for atrial fibrillation. So the remaining option what is left is, that is ABCD2. You have to remember it's a ABCD2 what we use for a risk of future stroke in a patient. So yeah, and the ABCD2 is usually, I'll just tell, ABCD is like A is age, that should be greater than 16. It's following parameters. I will just repeat. It's a age greater than 60, SBP, S is for SBP, 140 by 90 it should be greater than 140 by 90. Then we have a duration, then we have diabetes and total score that we have. So yeah, it's a ABCD2 scoring system. Next we have a patient who underwent an IOD insertion. Suppose the patient who underwent an IOD insertion is most likely to develop which of the following in the future. It's a OBG question and the options are it's a vaginal bleeding, abdominal pain, uterine perforation, or it's a pelvic infection. So yeah, if you just tell a patient who underwent IOD insertion is most likely to develop which of the following. Well, it's a complication. Adverse effect you can just tell it's a vaginal bleeding, abdominal pain, uterine perforation, or it's a pelvic infection. So yeah, you can just tell which is a common thing most likely to develop what with IOD insertion. Anyone? Okay, the answer here is it's basically it's A, that is the vaginal bleeding is the most common side effect for an IOD insertion. And that is also there, it's have abdominal pain, but it's the second most common. So the first is the vaginal bleeding, which is a perforation is C perforation. See, perforation is a, you can say it's a complicated thing, but most common is bleeding. Perforation can be there, we have no that perforation will be there, but we are saying most common side effect will be vaginal bleeding. And after vaginal bleeding we have abdominal pain, and then pelvic infection, perforation, pregnancy and all that it will be there. But yeah, the most common is vaginal bleeding, which you have to remember. Next we have which of the following tumor markers is least likely to be positive in a patient with multiple myeloma. It's CD56, SYNDACN1, it's CD138, or it's a CD21. So I'll just repeat, which of the following tumor markers is least likely to be positive. Just think, it's a least likely to be positive in a patient with multiple myeloma. CD56, SYNDACN1, CD138, or it's a CD21. So yeah, if you can just answer this, what is the case? Anyone wants to answer this? Which of the following tumor is least likely to be positive in a patient with multiple myeloma? CD56, SYNDACN1, CD138, or it's a CD21. Okay, I will just tell its answer is, you have to remember it's D is the right answer, CD21. So CD21 we don't use, basically we use what I am telling. So CD20, basically the answer is CD21, which is least likely to be positive in a patient with multiple myeloma. And CD56 and SYNDACN1 or CD138 will be positive for a case of a plasma cell tumors. Multiple myeloma is basically it's a plasma cell tumor only. So yeah, it's that way. Next we have, it's a psychiatric question. Which of the following is the most common form of acute transient psychotic disorder? Its options are acute polymorphic psychotic disorder without the symptoms of schizophrenia, and that is like acute polymorphic psychotic disorder with symptoms of schizophrenia. Or next we have acute schizophrenia, that is acute schizophrenia like psychotic disorder, and the last option is acute transient psychotic disorder, and that is unspecified. So yeah, if you understand, most common form of acute transient psychotic disorder. So let's repeat again. Which of the following is the most common form of acute transient psychotic disorder? Options are first, acute polymorphic psychotic disorder without the symptoms of schizophrenia. Second, with symptoms of schizophrenia. And then we have acute schizophrenia like psychotic disorder. And the last one is unspecified acute transient psychotic disorder. So yeah, the most common form, if you know. Okay, the answer here is basically it's, you have to remember it's A, that is the acute polymorphic psychotic disorder, that too without the symptoms. So it's the acute polymorphic psychotic disorder without the symptoms of schizophrenia, which is the right answer here. And then it is followed by the symptoms of schizophrenia. But yeah, so the most common form of acute transient psychotic disorder is it's an acute polymorphic psychotic disorder, that too without the symptoms of schizophrenia. Let's see, move on. It's an image based question here, but yeah. Which of the following papillosquamous condition is classified by the grip classification? Options are it's like 1, 2, 3, 4, all that they have given, but I cannot show you the image. I'll just tell the answer in this case basically. So yeah, you know what is the grip classification used for? At least you can just tell that if you know what is it. That is the 5 clinical types by the grip they have given. What is the use? It's a dermat question basically. So if you know what is grip classification. Anyone, what is grip classification? So it's grip classification is basically used for, it's a dermat condition, that is a pityriasis rubra pilaris. Okay, we divide into 5 clinical types. of it's a pityriasis rubra pilaris. We divide that the exact classification is divided into 5 types, and the 6th type is related to the HIV infection. So yeah, they have just given the image. I cannot just show you what they are. So yeah, we can just take a classification. It's a grape classification. Type 1 to type 6 they have given. Type 1 is classic adult, type 2 atypical adult, type 3 classic, that is juvenile, type 4 circumscribed juvenile, or type 5 is a atypical juvenile, and it's a type 6 is a HIV associated. So yeah, and there are 2-3 dermat condition also they have given. See, like it's if you have a lichen planus, what will be the clinical finding? In case of a lichen planus, it will be a white lacy reticular pattern. They have given the image, but yeah, I'll just tell you, it's a white lacy reticular pattern in case of a lichen planus. And if you have a pityriasis rosa, it's a colorate of scales. Yeah, it's a very classical finding. Colorate of scales is seen in pityriasis rosacea. And if you have a psoriasis, that too I think you might be knowing. If you have a psoriasis, we have it's a red plaque with basically it's a silvery lining. It's a silvery white scales will be there above the red plaque in case of a psoriasis. Okay, then we have, so yeah, you are a RMP, that is registered medical practitioner working at a PHC. A patient is brought to you with a history of consuming poison in an attempt to commit suicide. So which of the following statement is true? So yeah, I will just repeat. You are working in a PHC and a patient is brought to you with a history of consuming poison in an attempt to commit suicide. So which of the following is true? Options are: first, it is mandatory to inform the police before starting any treatment. It is mandatory to register a police complaint prior to inpatient admission. Then we have you are not bound by law to inform the police, and it is mandatory to call the police to the hospital prior to discharge. So yeah, it's a easy one. If you have done your casualty posting, then also you can just think, because whenever the patient comes, like any RT also it comes, you have to inform the police here. But yeah, I'll just tell the options once again. Which of the following is true? If a person consumes poison in an attempt to commit suicide, the options were: it is mandatory to inform the police before starting any treatment, it is mandatory to register a police complaint prior to the admission of the patient, or you are not bound to any law, or the last option, it is mandatory to call the police to the hospital prior to discharge. So yeah, anyone want to answer this? See, normally also when an RTA patient comes or any poison patient comes, we give an intimation to the police. But yeah, it is not in this case. Why? It is not in this case because, see, in suicide case, you are not, as a government medical officer, you are not required to report any case of suicide to the police, as suicide is no longer considered as a criminal offense. But yeah, I think we generally, or MLC, yeah, it's a MLC case, but we generally, I don't know what they have given the answer, but yeah, generally whatever, any poison also patient comes, we do a MLC case for that. But here they have given a government medical officer is not required to report any case of suicide to the police, as suicide is no longer considered as a criminal offense. So yeah, the right answer is C. So you are not bound to inform the police. Next we have is which of the following is a bispecific monoclonal antibody? It's a daratumumab, elmetuzumab, it's a blinatumomab, or it's a panitumumab. So yeah, which of the following is a bispecific monoclonal antibody? It's a daratumumab, elmetuzumab, blinatumomab, or it's a panitumumab. Anyone? I also don't know the answer, but yeah, anyone wants to answer this? Which is a bispecific monoclonal antibody? Okay, I will not tell because I also don't know the answer, but yeah. Okay, the answer here is basically it's a C, that is a blinatumomab is the right answer here. In blinatumomab is a bispecific monoclonal antibody. See, what is the meaning of bispecific? Bispecific means that it will attach to two sites. Normally what an antibody does, it attaches to the one site only. So yeah, it binds to two different types of antigen. Yeah, it binds to two different types of antigen, and if it binds, it is a bispecific monoclonal antibody. And the answer is it's a blinatumomab. So you have to remember. Next we have it's a pathological question. So yeah, the question is, it's a 25-year-old man who comes with the chronic anemia and gallstones. His family history is significant for similar illness. So, and then his peripheral blood smear you do, and what is the mode of inheritance of the given clinical condition? So yeah, I'll just tell you what is the image here. Basically they have given spirochetes. Yeah, So see, if they have given spherocytes, that too in the peripheral smear, so what is the diagnosis? If you can just tell, what is your diagnosis if you have a spherocytes in peripheral smear? Anyone? I'll just repeat the question. The question was, it's a 25-year-old it's a 25-year-old man who comes to you with a chronic anemia and gallstones. His family history is similar, has a significant similar illness, and his peripheral smear shows spherocytes. So yeah, with that only I think you can just tell, but okay, if you don't want to tell, it's a case of a hereditary spherocytosis. So in case of a hereditary spherocytosis, it's like it's what the options were: autosomal dominant, X-link, autosomal recessive, X-link recessive. So it's an easy question, but if you know what is hereditary spherocytosis, okay, the answer is very simple. It's a autosomal dominant. So to remember that in case of hereditary spherocytosis, it's a autosomal dominant disorder. So yeah, RBC will be spheroid, and RBC will be less deformable and more vulnerable to the spleen. Spleen means spleen sequestration and all that. So this decreases the lifespan of RBC. So yeah, that is there, but it's the autosomal dominant which we have to remember. Yeah, it's the autosomal dominant. I know there is some gap between what I say and you respond. It is because of the network issue and all that. But yeah, next we have, it's a 25-year-old female came with complaints of greenish discharge per vagina, and on examination she had strawberry vagina. So which of the following is the treatment for her? Options are doxycycline, amoxicillin, fluconazole, or it's a metronidazole. So yeah, just think, when you have a strawberry vagina, it's a very peculiar feature. I'll just repeat, it's a 25-year-old female, and that too greenish discharge. Greenish discharge and strawberry vagina is what? What do you think for that first? And then which of the following is treatment of choice for her? It's a doxycycline, amoxicillin, fluconazole, it's a metronidazole. So yeah, it's anyone? Okay, I will just tell. Yeah, it's a trichomoniasis. At first only you can just tell it's a greenish and strawberry service only, but yeah, they have given strawberry vagina, that only. But yeah, it's a case of, and you will give a metronidazole, you will give. D is the right answer. And the treatment regimen is like metronidazole 2 gram you will give a single dose, and or you can give metronidazole 400 mg BD or BD. It's 400 mg BD for 7 days. So yeah, there are two choices. You can directly give 2 gram single dose, or you can give 400 mg BD or TDS for 7 days. And otherwise, one you can also, yeah, in this case male partner has to be treated. So name one condition where you don't have to treat male partner. Anyone? A condition in which you don't have to treat a male partner. In Candida also you have to treat the male partner. In Trichomonas also you have to treat the male partner. But in which condition we don't treat the male partner? If you can tell. It's good only, but yeah. Okay, next question we will move on. Okay, I will just tell the answer for that. See, in bacterial vaginosis you don't treat the male partner. Otherwise, trichomoniasis, which we have done, trichomoniasis, and like in candidiasis also we have to treat the male partner. So yeah, moving on to the next question. It's a mother who brings her 3-month-old infant to the OPD with complaints of him crying while urinating. So on palpation, a left-sided plank mass is felt. USG KUB revealed dilatation of the pelvic calcareous system with the normal-looking distal urinary tract. So what is the investigation of choice to confirm this diagnosis? So I think it's basically that VUC, that is a vesicourethral reflux is the case. I think so. But yeah, I'll just repeat. Yeah. Okay, it's a mother who brings her 3-month-old infant to the OPD with complaints of crying while urinating. It's on palpation, left-sided plank mass is felt. USG KUB revealed the dilatation of the pelvic calcareous system with a normal-looking distal urinary tract. So what is the investigation choice for this condition? It's an intravenous pyelogram, 99M TC mercaptourethral side scan, or it's a maturing cystourethrogram, and the last option is it's a retrograde urethrogram. So yeah. So what I thought, it is not the, yeah. So yeah, what is the answer if you think? What is the diagnosis if you think for this condition? You can just tell. It's basically what I thought it was basically I thought it is a vesicourethral reflux, but it is not the vesicourethral reflux. It's a case of obstruction. Why? Because there is a flank, that is a flank mass. So if there is an obstruction, there will be you can see hydronephrosis in case of obstruction also, as well as in case of vesicourethral reflux. But yeah, it's a case of obstruction, and yeah. And the investigation for a obstruction, that is a UPJ obstruction. UPJ is what? It's a uretero-pelvic junction obstruction. So you will do a 99M TC mercaptourethral side scan. So you have to remember that. But yeah, if you think of a vesical urethral reflex, you will do a mitral cystourethrogram. So yeah, but why it's not vesical urethral reflex is basically because it's a flank pain and is trying while urinating. That is a typical feature for that. So yeah, but dilatation will be seen in that case also. So yeah, let's move on. That is last 3 questions I think. Remimazolone is administered to a 44-year-old man prior to an esophagogastroduodenoscopy. So which of the following statement is incorrect regarding the drug? So you have to tell a drug name I have given. It's a remimazolone. Okay, remimazolone, and we administered to a 44-year-old man prior to a esophagogastroduodenoscopy. Which of the following is incorrect? Options are: can be used for procedure 30 minutes or less, faster acting than midazolam, metabolized by a non-specific esterases, and new gamma B receptor agonist. So yeah, if you can just tell the answer here. Yeah, it happens. Okay, the answer is basically it's a D is the right answer. It's a remimazolone it's a new GABA B receptor agonist, and it's an agonist. It combines with the two drugs, that is midazolam and that is remifentanil, and it has strong GABA A receptor like midazolam, and has someone is calling but I cannot listen to it. So yeah, it is okay. So next we have 1 minute. Yeah, sorry for the disturbance. Oh, sorry, but yeah, it's like a remimazolone, which is I'll just mute the phone. Yeah. Okay, it's see, I was talking about remimazolone. Remimazolone is basically it's an ultra short-acting intravenous benzodiazepine, which is rapidly degraded in the plasma by non-specific esterases. That all you don't have to remember. But yeah, it's a new GABA B receptor agonist, and it's a benzodiazepine. So we have recently, it has been approved. I also didn't know it's recently been approved. Remimazolone indicated for induction and maintenance of a procedural sedation in adult undergoing procedure 30 minutes or less. So if you have a 30 minute or less procedure, you can give a remimazolone, and it is recently approved, so I also didn't knew that. But yeah, it's for induction and maintenance of a procedural sedation. Next we move on. It's a junior doctor sustained a needle stick injury while sampling on the blood of a patient who is HIV positive. So which one of the following regimen is recommended for the post-exposure prophylaxis? Basically, you are a doctor and by chance you injured the blood vessel, and the patient was HIV positive. Basically, what is the following regimen is recommended for a post-exposure prophylaxis? The options are zidovudine plus lamivudine for 6 weeks. It's a zidovudine, lamivudine plus nevirapine for 4 weeks. It's a tenofovir, lamivudine, dolutegravir for 4 weeks, or it's a zidovudine, lamivudine, indinavir for 6 weeks. So yeah, it's an easy one, but it's like if you know only you can just tell. The regimen is there for a post prophylaxis HIV patient. So yeah, anyone? So basically you have to give it's a OD only, I think. Yeah, it's a OD, that too for 4 weeks you will give, and the combination of the drug is tenofovir, lamivudine, and dolutegravir. D is not the right answer. No, D is not the right answer. You were thinking for pregnancy, I think you were thinking. No, it's not that case. I think, yeah. But the answer is C, that is a tenofovir, and lamivudine, dolutegravir, for 4 weeks you have to give, and that too once a day you have to give for 4 weeks. Okay. And you need to know the dose. It's a lamivudine 300 mg, tenofovir 300 mg, and dolutegravir 50 mg. And yeah, it's for 4 weeks. Next we have which of the following nuclei do not belong to the general visceral efferent column? Options are dorsal nucleus of vagus, endinger visceral nucleus, nucleus ambiguous, or it's an inferior salivary nucleus. So yeah, I'll just repeat. Which of the following nuclei do not belong to the general visceral efferent column? Options are dorsal nucleus of vagus, endinger visceral nucleus, nucleus ambiguous, or it's an inferior salivary nucleus. So yeah, anyone? See, anatomy, I am also weak in anatomy, but yeah, you have to remember there is no choice. Okay, the answer is C, that is the nucleus ambiguous is not a part of general visceral efferent column. And basically they have, it's okay, I'll just tell what are the parts of general visceral efferent column. It's the that is the Endinger Westphal nucleus, superior salivatory nucleus, inferior salivatory nucleus, or the dorsal motor nucleus of vagus. And you have to remember the nerves which I am talking. It's at 3, 7, 9 and 10 nerves which will be going through this nucleuses. So yeah, it's a general visceral efferent. And what I was talking, it's a nucleus ambiguous. It belongs to the special visceral efferent column. So it's a special visceral efferent column for a nucleus ambiguous, and others I told it's for it is a general visceral efferent column. So yeah, let's move on. Is the last question for today. A newborn male baby is being evaluated for posterior urethral valve. So what is the investigation of choice? It's MCU, TCDTPA, USG or DMSA. So it is a male baby newborn evaluated for posterior urethral valve. So it's MCU, DTPA scan, USG or a DMSA scan. So yeah, anyone? If we want to answer this, it's the last question for today. Newborn male baby is evaluated for posterior valve posterior valve. So what is the investigation of choice? It's a MCU, DTPA or it's a USG or DMSA. So yeah, what is the investigation of choice for posterior urethral valve? Anyone? It results from the formation of a thick valve-like membrane from a tissue of Wolffian duck origin. All that is okay, but yeah, okay, I'll just tell the answer there. It says A, that is the MCU is the right answer. That is the maturating cystourethrogram, or you can just tell it's a voiding cystourethrogram, which is the best imaging modality for posterior urethral valve. So yeah, it's over for today, and yeah, thank you so much for joining. Bye.